I think we need to start. First of all, thank you very much for everyone who attended, who will be attending this webinar with us. Thank you very much for our speakers for accepting our invitation. Today we will be speaking about a very important topic. It's about pulmonary hypertension, and it's a very critical topic. Our moderator will be today is Rania Al-Jamal, Dr. Rania Al-Jamal. I will introduce her. She is one of the best pharmacists I have encountered. She is a full-time lecturer in Jordan University of Science and Technology in the Faculty of Pharmacy, Department of Clinical Pharmacy. She graduated with a bachelor degree of pharmacy from Jordan University of Science and Technology. Then she followed this with a master's degree from the same university in 2011. She's an experienced pharmacist, and today she'll be with us to moderate this session. Please welcome with me Dr. Rania Al-Jamal. Dr. Rania, the floor is yours.
Yes. Thank you very much, Dr. Tamadur. Welcome everybody from wherever you are joined us this evening to attend our webinar titled Navigating Pulmonary Hypertension Management and Treatment Strategies. Actually, our speakers for today are Dr. Noura Al-Turaif and Dr. Faiz Al-Ahmadi, and both of them are known to have big expertise in the field of pulmonary medicine. And we are very pleased that you both fortunately accepted our invitation to discuss and present hot topics in pulmonary hypertension. And before heading to introducing our speakers, I want to remind the attendees, as usual, to drop your questions in the question and answer box during the presentation of each speaker, and I will take your questions sequentially after the completion of each presentation in order to be answered by the speakers separately. Now heading to introducing our first speaker, Dr. Noura Al-Turaif. We are hosting Dr. Noura. So you are welcome, Dr. Noura. Dr. Noura Al-Turaif graduated from King Saud University in Saudi Arabia with a bachelor degree in medicine and surgery. She had a residency training in internal medicine at King Faisal Specialist Hospital, in addition to a residency training in internal medicine at University of Virginia. Dr. Al-Turaif was a fellow in pulmonary and critical care medicine at University of Virginia, and then she was a fellow in pulmonary and vascular disease at Stanford University. Dr. Al-Turaif also has the American Board of Critical Care Medicine and the American Board of Pulmonary Medicine, in addition to the Saudi Board of Internal Medicine. Currently, Dr. Al-Turaif is an active pulmonary medicine and pulmonary hypertension consultant at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. And her current research is focused on evaluating the outcome of patients with pulmonary arterial hypertension. Dr. Noura will present and discuss pulmonary hypertension, definition, pathophysiology, and classifications. We will start with you, Dr. Noura. You are welcome again, Dr. Noura, and the floor is yours, and you can start your presentation now.
Thank you so much, Dr. Rania and Dr. Tamadur, for your kind invitation and your kind introduction. We're really excited to be here today and talk about pulmonary hypertension. Let me share my screen. Do you see my slides?
Yes, doctor.
Perfect. So today I'll talk about pulmonary hypertension definition, pathophysiology, and classification. And my objectives for today, I'll explain the new definition of pulmonary hypertension. I'll describe the pathophysiology of pulmonary hypertension, and I'll review the diagnosis and updated classification of pulmonary hypertension, and we will briefly describe the epidemiology and prognosis of each group. Just to make it more interesting, I think I'll start with a case. So we have a 17-year-old girl who started to have shortness of breath in 2019. Her shortness of breath was mainly with exertion, and at that time she was diagnosed with iron deficiency anemia, for which she was treated with IV iron. Her condition progressed, and in February 2023, she started to have worsening shortness of breath, now with mild exertion, and also she reported dizziness. She sought medical advice at multiple medical centers, and she was treated for anemia. In March 2023, she presented to the emergency room with worsening shortness of breath and multiple episodes of syncope. Her echo, which was performed in the ER, showed enlarged right ventricle and concern for pulmonary hypertension. And these are her initial images. You can see on the left side her chest X-ray, and you can appreciate the enlarged right pulmonary artery, and also the enlarged right side of the right side of the heart. This is mainly the right atrium, and both are signs of pulmonary hypertension. On the CT scan, you can, which was done, of course, to rule out pulmonary embolism, which is very important in her condition. So PE was ruled out. However, you can appreciate that the pulmonary artery is almost double the size of the adjacent aorta. And again, this is a really an important sign concerning for pulmonary hypertension. When you have the ratio between the pulmonary artery diameter and the aorta more than one, that's concerning. She was admitted and she underwent basic workup, and her 6-minute walk distance to assess her exercise capacity showed that she was able to walk only 224, which is way less than what she's expected to perform. And her pro-BNP, which is a marker of heart failure, whether right or left, was elevated at 694. And this is her echo. You can see that the right ventricle is bigger than the left ventricle, which is abnormal. Usually the left ventricle is supposed to be bigger than the right ventricle. And this is suggestive, again, of pulmonary hypertension. And the echo report showed a severely dilated right ventricle, severely reduced function, with a right ventricular systolic pressure of 90 millimeter mercury, concerning for pulmonary hypertension. So what is pulmonary hypertension? So when we have mean PA pressure more than 20 millimeter mercury by right heart catheterization, with a PVR more than 2 Woods units and normal wedge, meaning 15 millimeter mercury or less, you would call it pulmonary hypertension. And this is basically pre-capillary, because it's affecting the pulmonary artery before the capillaries. And you can see this in WHO group 1 pulmonary arterial hypertension, or pulmonary hypertension secondary to lung disease, or chronic thromboembolic pulmonary hypertension. However, when the wedge is elevated, this means it's post-capillary, affecting the pulmonary veins and the left side of the heart. And usually you will see it with left heart disease predominantly. The cutoff of pulmonary mean PA pressure was changed in 2018 after the World Symposium. Initially, the definition was mainly mean PA pressure more than 25 millimeter mercury suggests pulmonary hypertension. However, it was reduced to 20 millimeter mercury, and this is basically after multiple studies in normal subjects. They found that normal mean PA pressure is 14 plus minus minus 2 standard deviation. So the upper limit of normal will be 20, and that's why now it was reduced. Also, PVR more than 2. Initially, it was more than 3, but after the updated guidelines in end of 2022, the PVR was reduced to 2, and that's basically because mortality is higher when PVR more than 2. And we have 5 groups, and this is a basic WHO group classification of pulmonary hypertension. Group 1, PH, whether it's idiopathic, heritable, or associated with other conditions. It's the main topic we will talk about today, and it's mainly the group that we treat with our medications. Group 2 is secondary to left heart disease. Group 3 is secondary to lung disease. And group 4 is due to pulmonary artery obstruction, whether because of chronic clots or tumors. And group 5 is multifactorial. And group 1 pulmonary hypertension, you can see that it contains subtypes. So we have idiopathic, heritable, drugs and toxins, and with associated conditions, also pH with features of venous capillary involvement and persistent pH of newborn. So what's the pathophysiology of pulmonary hypertension? Here in this is a cross-sectional view of normal pulmonary artery, and you can see very good sized lumen with very nice thin layers of endothelial cells. And in pulmonary hypertension, this is completely different. You can see that the all layers are thickened with medial hyperplasia, intimal proliferation, and plexiform lesions, causing the pulmonary artery lumen to be really small and causing reduction in flow and elevation in resistance. And this is a histopathological figure just to show you the findings on histopathology. And we used to have 3 pathways focusing on targeting the vasoconstriction component of pulmonary hypertension by increasing nitric oxide and blocking endothelin pathway or improving prostacyclin production. And now we're lucky to have a TGF-beta activin pathway that also targets the hyperproliferative component of pulmonary hypertension. And I'm sure Dr. Faiz will talk more in the pulmonary hypertension management about all the medications we have to treat those patients. And despite the diagnosis supposed to be based on elevation in mean pay pressure and PVR, the prognosis is really driven by the right ventricle, because the right ventricle will be handling and trying to adapt for the increase in the pulmonary pressures. And with time, the right ventricle will enlarge to maintain contractility and coupling with the pulmonary artery. Also, the heart rate of the patient will increase to support cardiac output and contractility until the patient RV fails to adapt anymore, and then RV failure happens and cardiac output goes down. In this table, I just wanted to highlight that age at diagnosis from our pulmonary hypertension registry in Saudi is around 30. And our pulmonary hypertension patient usually really young. And if you have a young patient with shortness of breath that you can't explain, it's really worth it to screen for pulmonary hypertension. What are the clinical signs and symptoms? The clinical signs and symptoms of pulmonary hypertension are vague, and that's why most of the time pulmonary hypertension diagnosis gets missed. Usually they present with dyspnea on exertion, fatigue, palpitations, hemoptysis. When they get advanced disease, they present with presyncope or syncope. It's really important when you examine those patients to look for loud P2, TR murmur, and signs of other associated conditions like clubbing or cyanosis in the setting of congenital heart disease. You can look for Raynaud's phenomena, digital ulcers, skin rash, suggestive of underlying connective tissue disease, and so on and so forth, that will increase your probability of having pulmonary hypertension. And usually when we see them, we do basic screening and diagnostic tests. We do EKG, chest X-ray. We do blood tests to evaluate for connective tissue disease serologies and infections such as schistosomiasis. Full PFT is important to evaluate for an underlying lung disease. You could do ABG to assess for hypoxia. If you have cardiopulmonary exercise testing, it will be very helpful in those patients. However, echo is really the most important non-invasive screening tool in evaluating someone for pulmonary hypertension. VQ scan, usually we do it to rule out clots, and CT chest with contrast to evaluate for pulmonary clots, and lung parenchyma for underlying lung disease. We do also ultrasound abdomen to evaluate for liver disease and portal hypertension. And finally, we confirm diagnosis by right heart catheterization. In this figure, you can see the distribution of WHO group 1 pulmonary arterial hypertension based on regions. And you can see that in the Middle East, pulmonary hypertension is predominantly, group 1 is predominantly due to idiopathic pulmonary hypertension, followed by congenital heart disease, followed by connective tissue disease. However, if you see North America, it's basically idiopathic, followed by connective tissue disease, followed by congenital heart disease. And again, in South America, you can see that schistosomiasis is more prevalent there. So distribution is really varies according to the region you live in. So now we'll talk about the idiopathic heritable and drugs and toxins PAH from group 1 pulmonary hypertension. So vasoreactive PAH is really a unique subtype of group 1 PAH, and it's basically in the cath lab, they give those patients nitric oxide at 20 parts per million. When you see sudden drop in the pulmonary pressures, more than 10 points, and to an absolute value of 40 or less with stable or improved cardiac output, you call them vasoreactive. Those patients are unique because they have really good prognosis. This condition affects less than 10% of patients with PAH. And you do this vasoreactivity testing in idiopathic hereditary or drugs and toxins. You don't do it in all types of pulmonary hypertension. And this group of patients, usually we treat with high dose calcium channel blocker, not with the regular pulmonary vasodilator therapy. Heritable pulmonary hypertension is an autosomal dominant disease with incomplete penetrance. We have a lot of mutations that can cause pulmonary hypertension. BMPR2 mutation is the most common one and affects 20%, has 20% risk of developing PAH. But there are other mutations like ALK1, SMAD9, and AIF2AK4 mutations. And we have also different mutations than the Western countries due to the consanguinity in our population. I think the key message from here is when you have asymptomatic relative that has that did screen positive for PAH causing mutation, you need to screen them yearly with an echo to catch pulmonary hypertension early and treat them early, because prognosis of heritable PAH is not really good. PAH associated with drugs and toxins. This was discovered in 1966 and until 1970, when the epidemic of aminorex use associated with PAH was found. It's basically a lot of young females were using aminorex to lose weight, and during that time they found a lot of females dying because of heart failure. And since then, we've discovered a lot of medications with definite association and medications with possible associations. And for example, aminorex is one of the definite associations with PAH. Dasatinib is also associated with PAH, and methamphetamine. And of course, possible associations, you can see it in cocaine, amphetamine, and other immune suppressants like cyclophosphamide or leflunomide. Patients with drugs and toxins, usually they exhibit similar clinical function and hemodynamic characteristics of idiopathic PAH. The only difference is you could reverse the disease when the patient withdraw the medicine or you withdraw the medicine that's causing the pulmonary hypertension. Dasatinib, for example, affects 0.45% of patients treated with this medication, and it's usually associated with pleural effusion, and reversibility is really common if you withdraw dasatinib. Next is the pH associated with other medical conditions. So we have connective tissue disease, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis. So pH associated with connective tissue disease is really an important subtype of pulmonary hypertension, affects females predominantly. Our patients affected at younger age compared to the Western countries. It's really important to think of pulmonary hypertension when you have someone with scleroderma or scleroderma spectrum disease. If you have someone with SLE, Sjogren, dermatomyositis, it's really important to screen those patients with echo yearly, also to catch pulmonary hypertension early and diagnose them and treat them early. And that's basically because the prognosis of connective tissue disease really disease. And here you can see a curve of survival of comparing CTD PH to those with idiopathic PH, and you can see survival is worse when you have underlying connective tissue disease. And that's basically because also they don't respond to therapy as well as idiopathic PH. And it depends, the pulmonary hypertension development usually depends on the lesion and the time you discovered the lesion and whether it was closed or not. Here you can see that truncus arteriosus 100% causes early PH. If you have VSD or PDA, you have 50% risk of having pulmonary hypertension. And if you have ASD, usually it tends to cause a late pulmonary hypertension. And basically, pulmonary hypertension in congenital heart disease, a patient will present with worsening shortness of breath. And when you evaluate them with right heart cath, you will discover that they have progressive elevation PVR suggestive of pulmonary hypertension. This is a busy table, but I just wanted to highlight that patient with congenital heart disease, whether they have Eisenmenger syndrome, which manifests as really hypoxia, cyanosis, and secondary erythrocytosis, or if you have correctable or non-correctable congenital heart disease shunt, or a defect that was corrected, you're still at risk of developing pulmonary hypertension. And the key message from here is when you have congenital heart disease with right to left shunting and evidence of pulmonary hypertension, closure is really contraindicated, and treatment is basically with our pulmonary vasodilator therapy. Prognosis of congenital heart disease patients is better than idiopathic, and that's basically because they can compensate and unload the right ventricle by shunting from the right side to the left side, and they sustain cardiac output at the expense of hypoxia and cyanosis. Next is pulmonary hypertension associated with portal hypertension, and it affects 2 to 6% of patients with portal hypertension with or without liver disease. And it's really important to realize that pulmonary hypertension can affect those with portal hypertension, and you don't really have to have liver disease. And there are multiple reasons to have high pulmonary pressures in someone with liver disease. And that's basically because they have hyperdynamic circulation and their cardiac output is high. And because the cardiac output is high, pulmonary pressures will be high. And you don't treat those with pulmonary vasodilator therapy. Also, they tend to get volume overload. And if you cath them, you will see high wedge with elevated mean PA pressure, but their PVR is normal. And you, at this case, you just optimize their volume status. And portopulmonary hypertension is basically when you have elevated mean PA pressure with elevated PVR and normal pulmonary capillary wedge pressure. And I think this is really important to manage before liver transplant and screening any patient with liver disease with an echo is very important, because having pulmonary hypertension before transplant is a contraindication. And usually they should be managed and optimized before transplant. And of course, screening those going for TIPS procedure is, again, important to prevent decompensation. pH associated with HIV prevalence is about 0.46%. There is no correlation between severity of pH and stage of HIV infection. And because it's not common with low prevalence, we don't really screen for it, but you keep it in mind if you have an HIV patient with worsening shortness of breath. And then pH associated with schistosomiasis, it affects 5% of patients with hepatosplenic form. It's the leading cause in South America, as you saw in that figure, Africa and Asia. It's really rare in Saudi Arabia, and maybe you find some cases in the southwest part of Saudi. Prognosis is good compared to idiopathic. They have higher output and lower PVR and better survival. And then pH with features of pulmonary veno-occlusive disease, or PCH. It's a unique form of group 1 pulmonary hypertension because it affects the venules. And this is the only form of pulmonary hypertension that you could see pulmonary edema on chest imaging. It affects 10% of patients. It's male predominant and carries really worse prognosis. Could be hereditary due to the mutation in the EIF2AK4 gene, or associated with other conditions. You could have scleroderma patient with PVOD, or you could have a patient with an underlying autoimmune disease treated with cyclophosphamide, and they develop this condition. So we're done with group 1 pH that we usually treat with our therapies. I'll touch briefly on the other groups of pulmonary hypertension. So group 2 pulmonary hypertension is the most common etiology of pulmonary hypertension and affects 65 to 80% of cases. And this is the type where you see pulmonary edema, cardiomegaly, or chest X-ray. And if you see the echo, and if you recall the prior echo of our patient, the left ventricle here is the dilated and weak part of the heart instead of the right ventricle in group 1 PAH. And when you have elevated PVR, prognosis is worse, and more than 5, you call it severe disease. Group 3 pulmonary hypertension affect those with end-stage lung disease, whether it's COPD, emphysema, ILD, combined pulmonary fibrosis and emphysema, or hypoventilation syndromes. Usually, we manage the underlying condition. More than 5 Wood unit PVR is suggestive of severe disease, and really treatment options are limited, and usually lung transplant will be the ultimate option. Group 4 pH is basically when you have obstruction of the pulmonary arteries, whether because of fibrotic clots or because of other pathologies like tumors in the setting of renal carcinoma, or arthritis or vasculitis. And this is a picture of fibrotic clots removed from one of our patients after undergoing pulmonary endarterectomy. And basically, treatment of chronic thromboembolic pulmonary hypertension is based on the distribution of the obstruction. If you have a proximal lesion, meaning a lesion in the large pulmonary arteries, then surgery is a good option. If you have a disease affecting distal pulmonary arteries, then other options like medical therapy or balloon angioplasty are more appropriate. And then group 5, sorry, this is group 5, is basically when you have mixed groups of diseases that we don't understand the mechanism of them causing pulmonary hypertension, such as in the setting of sickle cell disease, thalassemia, CKD, or sarcoidosis. And basically, we treat the underlying etiology, and we don't recommend pulmonary hypertension therapy. So back to our patient, she underwent right heart catheterization since it's our way of confirming diagnosis. And her RA pressure was 11, and it's elevated because normal is supposed to be less than 5. Her PA pressure the mean is 107, which is super elevated. If you remember, we said the cutoff is 20. Her wedge pressure was normal, around 9. Her cardiac output is low, 2.47, and normal is 4 to 6. And her PVR, we said more than 2 suggestive pulmonary hypertension, and her PVR is really elevated at 39. So she completed full pulmonary hypertension workup, and it was negative for associated conditions. We diagnosed her with high-risk idiopathic PH, and you will learn more about risk stratification from Dr. Faiz in his lecture. So we started her on dual oral therapy, riociguat and macitentan, though she would be more a good candidate for prostacyclin, parenteral prostacyclin, given the severity of her disease. However, not everyone will agree to start pump therapy from the beginning. And usually we follow those patients very frequently and just to make sure they are doing well, and we optimize their therapy. So we saw her 1 month after starting dual oral therapy, and we started the third oral therapy with selexipag. And she really did well, and you can see that her proBNP, which is a marker of heart failure and stress on the heart, improved to down less than 100. Also, her exercise capacity improved from around 200 to around 500. Also, we repeated her right heart cath, and it showed significant improvement in her numbers with improvement in the cardiac output. So during her last follow-up, her function class was 1, meaning she did not have shortness of breath with exertion, and her proBNP improved to 42, and she walked 495, and she was at low risk strata, and this is what we usually try to achieve when we treat our patients to optimize their outcomes. This is her echo after treating her with pulmonary vasodilator therapy, and that's why I presented this case just to show that treatment with our pulmonary vasodilator therapy is not only to improve function class, exercise capacity, but also it can reverse the RV dysfunction. So her echo, basically, the right ventricle is normal in size and function. She did have element of pulmonary hypertension with an RVSP of 50 millimeter mercury, but I think that's a really good achievement with therapy. So my key messages are PH is a rare disease, but keep it in mind, especially if nothing explains patients' dyspnea. PH affects younger adults compared to Western countries. Thus, early diagnosis management are important. Early referral to expert PH centers and confirmation of diagnosis by cath are key to improving survival. And of course, don't forget to screen high-risk population with echo, especially those with scleroderma spectrum, portal hypertension before liver transplant or TIPS procedure, and those with a positive PH mutation. And thank you.
Okay. Many thanks to Dr. Noura for the valued presentation discussing pulmonary hypertension, definition, pathophysiology, and classifications. It was really interesting to know more about pulmonary hypertension. Please again, dear attendees, do not miss the opportunity to leave your questions in the questions and answers sections. So we will go to some questions. Actually, we have many questions for you, Dr. Noura. We will start with the first question asking from, it's from Hind Muata. She asks, what strategies can be employed to overcome the barriers to early diagnosis of pulmonary hypertension, especially in resource-limited setting?
I think once everyone keep in mind that pulmonary hypertension is really a disease of young, and even if you don't have all the diagnostic tests, but if you see a patient and you're concerned about pulmonary hypertension, and you do echo and you don't really have resources to do right heart cath, or you don't have any resources to do further workup, just refer them. Refer to pulmonary hypertension centers. They do all the workup. And if they get diagnosed with pulmonary hypertension, they will be treated and diagnosed early. And if they don't, then they will be at least evaluated for it.
Okay. Another question from Hind asks, what are the most critical gaps in current pulmonary hypertension research? And what directions should future studies take to address these gaps?
Well, there are a lot of gaps. And probably I would talk more about in the Middle East. I think we need to do a lot of research work on understanding our patient population, because our patients are completely different than the Western patients. For example, I mentioned that connective tissue disease, pulmonary hypertension, usually diagnosed in elderly in US, for example, like 50s, 60s. However, in Saudi here or in the Middle East, usually they get diagnosed in 20s or 30s. So I think we need a lot of research to understand our population, understand the genetic mutations that predispose patients to heritable PAH, because also consanguinity is more common here than outside. I think the pulmonary hypertension experts should work on researching these outcomes to improve patient care and improve the gaps.
Okay. One more interesting question. Is there a role for stem cell therapy? So how might advances in stem cell therapy, genetic research, and regenerative medicine offer new hope for reversing the progression of pulmonary hypertension? So is there a role for it?
Not unfortunately for now. Maybe it will have a role in the future. But we do have, as I mentioned, a fourth pathway to treat pulmonary hypertension. Usually we manage the vasoconstriction part, and we were hoping to have medication to reverse the hyperproliferative part. And now we have sotatercept, and this is really a significant improvement in the field of pulmonary hypertension, and it reverses the hyperproliferation and improves even patients on triple therapy, including parenteral prostacyclin.
Okay. We will move to another question. Okay, so is there a first choice of treatment? I mean, can you name the drug of first choice treatment to pulmonary hypertension?
Sure. So you will learn more about management of pulmonary hypertension with Dr. Fayez, but I would say if you have the standard of care, you treat pulmonary hypertension patient with dual therapy. So the Ambition trial in 2015 showed that survival is better when you treat them with upfront dual therapy compared to monotherapy or sequential double therapy. So it's very, very rare you will see a pulmonary hypertension patient on single drug. So usually it's dual therapy, and you will learn more from Dr. Faiz.
Okay, yes, we will do that. Okay. One more question. We will ask about the beta blockers role. So if the patient, if the patient is having pulmonary arterial hypertension due to portal hypertension, then are we able to